Okay, welcome everybody to this month's Miami Global Brain Tumor Symposium. Very excited for this month for our guest speaker and to continue this symposium on a monthly basis. Again, we always want to say thanks to everybody who's helped us in the past, especially to the directors and the administrators who really make this possible every week. I want to especially thank my co-directors, Dr. Morcos, who's professor and co-chairman here at the University of Miami, Dr. Komatar, who's a program director of our residency program, and Carolina Benjamin, who's director of our skull-base Keynes lab, as well as all the administrators here, Christina, Ingrid, Roberto, Damari, and Ignacio, who've just been extraordinarily helpful in putting this symposium together and continuing it. And just to remind everybody that anything you miss and any of the past or future symposiums can always be watched on YouTube. We try to even log in sometimes and respond to the comments. We have over 10,000 views already of all of the seminars that have been done by both the Brain Tumor Symposium, the Skull-Base and Vascular Symposium, and the Pediatric Symposium. So please be sure to check those out if you missed any of them in the past. So just some housekeeping, the most important thing is really just we try to make this as interactive as possible. We try to get to everybody's questions, so please use the Q&A button to interact with us, and we'll try to get to everybody throughout the talk tonight. This week we have again another Miami consortium of panelists. Dr. Higgins, who joins us, who's actually one of the mentees of our speaker tonight, both from Columbia and both have a strong science background. Dr. Patel, who joins us from Rutgers and now our fellow, and Dr. Morel, who is actually our future clinical fellow, currently research fellow at University of Miami. So thank you all for joining us. Tonight, we welcome a very special friend of mine, Dr. Sanaban, who's joining us all the way from Chicago early in the afternoon, and we thank him so much for separating out this part of his day to talk to us about. He's doing so much work in so many different areas, but particularly he just had this fantastic work published in Nature Medicine, and we thought it was really impactful and wanted to invite him to come speak to us. Dr. Sanaban, he grew up and did his medical training in Mexico, graduated first in his class, and then came to the United States, did research in Chicago before going to Columbia, where he did his residency program for neurosurgery. Then shortly after, he joined Northwestern, has been extremely productive, has many publications, a long list of awards that I won't go through, and an NIH-funded research lab where he really focuses on treatments for glioblastoma. So Adam, thank you so much, and congrats on your recent success, and we're really looking forward to your talk tonight.
Thank you, Michael, and the organizers are really, it's an honor to share some of the work that we're doing here. I'll just jump right in. Can you guys see my screen? Excellent. So first, starting with conflict disclosure, I'm an author in some of the patents related to some of the work will be presented today. Unfortunately, no revenue so far. But anyway, I wanted to start by explaining the rationale for doing this investigation. And maybe start the talk with a little bit of an anecdotal background. Maybe it's 7 years now that I started a practice coming out of residency operating in brain tumors. At the time I was faculty at Columbia. And, you know, most of the gliomas I was doing were recurrent glioblastomas. And it was a really tough, not that it's much easier now, but it was a really tough situation to be in, because just like there's a clear path for how glioblastoma patients need to be treated when they're first diagnosed, you know, when the tumors come back, there's really nothing, no great evidence supporting any kind of treatment that would show that it would make people live longer. So this is what I was calling at that point no man's land. It was not clear what needs to be done for these patients. As we know, as surgeons, we can do, I think, a great job and get a patient symptoms to improve when they're related to mass effect. We can actually get great looking MRIs and great surgery, but you know that these victories are not long lasting and these tumors ultimately come back. What was special about that period is that there had been a major revolution in cancer care. There's 2 people getting Nobel Prizes. There's lethal cancers that had a reputation as bad as glioblastoma, such as melanoma and lung cancer, suddenly having long-term remissions for patients who had very advanced disease. And this big revolution was related to immunotherapy for cancer. And the first few agents approved were PD-1 blockade agents. It was really remarkable. And the unique aspect of that period is that there was no negative data for glioblastoma when I started. So at that point, well, the rationale is it works in all these other cancers. We have nothing to offer to these patients. I just did a nice surgery and I got a tumor out and the scan looks good. Patient's doing well. What next? And I was maybe partnering with a colleague of mine, Fabio Iwamoto, who's a great neuro-oncologist there. And we were just every patient systematically treating with PD-1 blockade. And we kept doing this over and over. And I will confess, most of the times we would get pretty disappointed by the results. But occasionally we would have something that really looked like a response and patients do well. We had very severe inflammatory responses and some patients were outliving our expectations. And that was really interesting. Of course, as we started getting more interested in it, the results of the large randomized phase 3 clinical trials started coming out, starting with the Checkmate 143, showing really no overall survival benefit for these patients compared to BEV in the recurrent setting. So by then we had already treated roughly 60-something patients. And it was really interesting because we were seeing some patients that maybe didn't read that paper, or if you will, or that just had a really nice response. So there was this dichotomy between what the overall survival data was showing and some of the anecdotal experience we were getting. And so we were very motivated to try to determine what was different about these patients. And we did a very nice partnership between me and Fabio and Raul Rabadan. And we decided we were going to study these tumors in a systematic way, in an unbiased fashion, and try to determine what makes these patients somehow different. And so this was a retrospective study in which we evaluated patients who were treated with PD-1 blockade at recurrent setting. We included 66 patients. And in order to figure out what's different about them, we needed to define success. We needed to define response. And the way we defined that was both radiographical or pathological. And so radiographic response was defined as over 6 months of stable disease after beginning of immunotherapy, which I thought was a stringent definition, considering most patients, the median survival after recurrence is about 9 months. And then pathological, well, if a patient had a tumor that appeared to be growing, and we happened to take the patient to the operating room, occasionally we would see that in fact, there was no tumor. There was just really a massive inflammatory infiltrate. And what appears to be enhancing disease was just a pseudo-progression. So if a patient had that scenario, we would consider that also a responder. And what we did on this paper is we considered that, all these variables: demographic, therapy, imaging, survival, gene expression, genetic and histological. And we looked at all these different things, and we studied somatic mutations, copy number variants, HLA typing, neoantigen predictions, tumor purity, employee, differential expression, TCR profiling, immune infiltration. And some of the interesting thing that we discovered right away is that our definition of response, which was purely based on imaging and or pathology, did not involve survival, was actually associated with patients living longer. So if the patient that we were calling responders were actually going to live longer. And what's really special and interesting is that we took every other potential confounder factor that has been published out there, whether patients were on steroids, whether it was a first recurrence, what PD-1 inhibitor this was, whether a patient got re-radiation, temozolomide, gender, and none of these had such an important impact on survival like response did. So you can see here the overall survival curves for responders and non-responders really show that these two kinds of patients were living differently. Here's two examples. At the time this was ongoing, I actually had relocated to Northwestern, and I was able to add a few extra patients from Northwestern. And these are actually 2 Northwestern patients that I included on this study. This first patient, NU7, was started with PD-1 blockade. And within 6 months, he had progression within 2 months and eventually passed away. And you can see here the progression very quickly. Whereas NU11, it's a patient that went on for about 17 months without seeing any additional tumor growth. And so we then did this genomic characterization. This is worked on closely in collaboration with Raul Rabadan and his team. And we look at all the genetic alterations. And what was really interesting here is that P10 mutation and deletion, which is a very common thing in glioblastoma, present maybe in about half of the patients, was somehow overrepresented in the non-responders. That's maybe interesting and perhaps compelling, but really anticlimactic when trying to figure out how to treat patients, because it's not great to have a negative biomarker that tells you who's going to do poorly. You would really like to get a biomarker that would explain who might actually do well with this treatment. On the other hand, the other interesting finding here is that there were 2 mutations in 2 genes, one in BRAF and the other one in PTPN11, that were really overrepresented in the responders. These 2 mutations are very rare. If you look at the number of patients that have this with glioblastoma, it ranges between 2 to 3%. But they're actually present in 30% of the responders. And what's really interesting is that these 2 genes that are different from each other, they both are effectors of the MAP kinase pathway. And both of these mutations have been reported to activate this signaling cascade in glioblastoma. And so I'll show you here the overrepresentation of these 2 mutations versus the background of TCGA patients, BRAF PTPN11 and the responders and P10 and the non-responders, and also the overrepresentation of the responders versus the non-responders, including these 2 that were in the responders and these in the non-responders. So we, at that point, had determined that there was something to MAP kinase pathway, and it was interesting, but honestly, it was not really sufficient to use this for clinical care. Because if I were going to talk to a patient, I would say, let's do this assay, and you have 2 to 3% chances of having a positive result. That might imply that you might do well with this immunotherapy. But if you do not get this result, you can still maybe benefit from this immunotherapy, as 70% of the patients that benefit didn't have this. It's really not a practical biomarker, and no patient probably would go for that. But I thought of that as a clue, because why would 2 separate genes have activating mutations that are super unlikely, are tenfold more likely to happen in responders? Both tend to signal that MAP kinase signaling has something to do with this. And so at that point, I was motivated to do this second analysis that we recently published in Nature Cancer. This, I would like to make here a parenthesis. This is the work by a postdoc and a former medical student in my lab, Victor Arrieta, who I like to make a parenthesis and say that he will be applying for neurosurgery next year. Stellar applicant, look out for him. And so anyway, when I started this, I said, Victor, why don't we try to figure out if just the tumors of patients that respond to immunotherapy have MAP kinase activation, regardless of whether they have a mutation or not. And so that's what Victor work is centered on. And if you, not to bore you with a very complicated cartoon of the MAP kinase pathway, but suffice to say that at the top you have RAS, and RAS phosphorylates RAF, including BRAF, and MEK1 also phosphorylates MEK2, and RAF phosphorylates MEK2. And so all these genes that we saw mutated, including BRAF and PTPN11, that is right here, it's a phosphatase, end up phosphorylating ultimately ERK. And ERK phosphorylation is actually a very nice way to see whether the pathway is active or not. And what was really cool and convenient is that there's really nice antibodies that can let you figure out if ERK is phosphorylated in tumors or not. And so these antibodies are monoclonal, they're nicely established. There's, I think for this antibody that we use, there's, I think, 40,000 citations for this work. It's a really nicely established antibody that works really well. And so what we did is we took patients, tumors, and we took unstained slides, and we started staining for phosphorylated ERK. Of course, there's tumor heterogeneity, and there's on any given slide areas that have tumor and areas that don't have tumor. In order to center our analysis on the tumor regions, we had a blinded pathologist who outlined the tumor regions, and we really then scanned those tumor regions for ERK phosphorylation. And we used a machine learning algorithm, and we set up a threshold, and we segmented individual cells. And then we determined with a threshold what percentage or how many cells on a square millimeter of tumor are positive for phosphorylated ERK. And what we did is, we did this in a cohort of patients that got adjuvant PD-1 blockade. There were 29 patients. But in order to determine whether this is a predictive biomarker or not, we did the same analysis in a similar size cohort of patients with recurrent glioblastoma that never got immunotherapy. And what I'll tell you right now is that there were no real clinical differences between these two cohorts of patients. They had similar age, male to female ratio, Karnofsky, MGMT promoter methylation, and IDH1 mutation status. So nothing different between these two groups of patients. The other very important point, and anybody who's savvy about molecular biology and phosphoproteomics will right away tell you, well, yeah, but phosphoproteomics are very labile, and you will actually have degradation of the phosphorylation very quickly. And of course, this is a problem, and it's a problem I want to warn you of, because if you were to consider this for a clinical trial that you're working or for trying this on a patient, you need to make sure that the sample that you have has enough and high quality tumor where ERK has not been degraded. It's important to know if a sample is low, that it is because there's just not MAP kinase activation in that tumor, and it's not because the sample was sitting around for too long. And what's really nice and convenient is that turns out that the endothelium, which is something that is easy to find in glioblastoma, really has very strong signaling for MAP kinase. So you can see here, there's an endothelial cells and capillaries, and there's a lot of staining for phosphorylated ERK. You see here a different sample, a different specimen. There's also a lot of staining. This other one that has very little phosphorylated ERK in the tumor still has phosphorylated ERK in the endothelium. And so in order to get some mental peace of mind that the samples that we were dealing with all had good quality, what we did is we took glioblastoma samples. I was operating on these patients, and we would extract the tumor, and we would split the tumor into several pieces. One piece we would fix immediately. Another one would wait half an hour, just let it sit there. Another one for an hour, another one for 2 hours. We did this over and over, and then we stained and started quantifying the intensity of ERK staining in the endothelium. And by doing this with these 3 patients, as you can see here, we showed that up for the first hour, there's no real degradation of ERK. But after at hour 2 and afterwards, you start to see degradation. And so we knew as long as the patient specimens have been waiting for less than an hour before being fixed, they were going to be easy to assess. And what we then did is we took the cohort of patients that we had done, we were considering for this analysis, and just look at how much endothelial PRK staining there was. And we never found any significant decrease in any of these samples compared to the specimens that we fixed immediately. We also extracted protein, and we were able to determine that for PRK and for other phosphoproteins, the degradation started really around 2 hours, as I can show right here. The other point that we wanted to prove, to be very rigorous about this, is that whatever staining we were getting was truly representing phosphorylated ERK. And in order to do that, what we did is we bought this neutralizing peptide that competes for the antibody. So when you add the neutralizing PRK peptide, you lose the staining, both by immunohistochemistry as well as for Western blot. You can see here the PRK staining on these patient samples and in cell lines. But when you add this phospholipeptide, you lose the PRK staining but you do not lose the staining of other phosphoproteins. So we knew that the specimens we were dealing with had high quality and were well preserved to study ERK phosphorylation, but we also knew that we had an antibody that in the conditions we were using was actually really staining specifically for PERK. So once we had these technical hurdles overcome, we started analyzing these patient cohorts. This is actually an interesting patient of mine at Columbia. As you can see, he had this very massive bifrontal glioblastoma that was already recurrent, and I operated on him. He did well from surgery. He was actually BRAF mutant. This is one of the patients that had BRAF mutation. We started him on PD-1 blockade, and this is a scan 2 weeks later. And actually about 10 months after surgery, he was still on PD-1 blockade. He already outlived the median survival for patients with recurrent glioblastoma. At that point, he developed massive hydrocephalus. It was very difficult to manage. I wouldn't be surprised if Dominic remembers this patient, because we really had a very hard time dealing with this hydrocephalus. It was extremely low pressure. There was a lot of protein in the CSF, and it was really difficult because the viscosity of his fluid was really, really profound. And as we got the ventricular drain on this patient, we obtained CSF, but at some point I also performed a biopsy because it seemed like this lesion in the right frontal area exhibited some growth over the last 10 months. And we needed to know whether this was actual recurrence after immunotherapy or whether he should continue on immunotherapy. And so we biopsied that. And interestingly, when we did analysis by flow cytometry, the resected tissue had a lot of CD4 and CD8 T cells, same thing as the cerebrospinal fluid. And when you stained his tumor, initially, no surprise because he had a BRAF mutation, had a lot of phosphorylated ERK. Of course, he had ERK also in the endothelium, proving that the quality of his sample was good. But when we did this biopsy 10 months later, we didn't really find any viable tumor. And the pathologists were saying this is just an inflammatory profile. And when we stained for CD3, we saw it was full of T cells. And so here, as a way of a comparison, there was another patient. This is a Northwestern patient who started after surgery. It was started on immunotherapy. And 2 months later, he exhibited some progression. He was dead by 6 months later. We stained his tumor for a phosphorylation of ERK, and we did not find a significant elevation of it, but we still had staining in the endothelium, proving that the sample was good. So when you look at our definition of responders versus not, the responders had high elevated ERK, whereas the non-responders had a spectrum. This is very important. I don't want to oversell this biomarker. There's a good chance that a patient that has elevated PERK might not be a responder. But what we never observe is that a patient that did well had low levels of PERK. And so, of course, we don't care about response and MRI findings. What we really care is about how long do these patients live. And so we abandoned the radiographic definition of response, and we focus now really on how long were people living. And there's two ways to do this kind of analysis. One is with a Kaplan-Meier log-rank test, in which we would basically take the spectrum of PERK values and cut them right in the middle. So we would use the median for PERK. And when you do that, you can generate these Kaplan-Meier curves, and you can see the cohort with no immunotherapy had no difference in survival for high versus low PERK. The patients that had PD-1 blockade, actually it was a significant longer overall survival of patients with high PERK compared to the low PERK, but also these high PERK patients that got PD-1 blockade were living significantly longer than the high PERK that did not get immunotherapy. And so this was exciting. The more rigorous way to do this analysis is in a continuous fashion. That's what we use the Cox model for. In other words, the question is this survival difference that we're seeing somehow an artifact based on how we split the data? Or would you have this no matter how you split it? And the continuous analysis would say, well, for every increment of phosphorylated ERK, patients should live longer. And it turns out that this was the case. You can see here, PERK was protective for overall survival on this cohort of patients who got immunotherapy and the univariate, as well as in the multivariate analysis. But then we applied the same analysis for patients that did not get immunotherapy. And of course, PERK had no bearing whatsoever on the overall survival. with this in mind, I think we can think of this as a predictive biomarker as opposed to a prognostic biomarker. These raw curves are very important standard. The ideal raw curve will have basically an area under the curve of 1. And so ours was 0.78. And the non-immunotherapy cohort behaves almost as random. And so this was exciting, but of course, the question is, can this be reproduced? And is this actually something we just got lucky on, or can you do it again? So that's something we'll get to in a minute. The other important point here is exactly the motivation for starting this second paper, this second analysis that we did not resolve on the Nature Medicine previous publication, which is, can we now really identify patients that will survive long after immunotherapy, even if they don't have these mutations? And the answer is yes. If you take, again, just like with response, the overall survival for patients that live past 1 year, they had significantly higher PR than the patients that live less than a year. Of course, the patients that live less than a year, some also had high PR, but there were no patients that live past 1 year that had low PR. And what's really interesting here is that you can see in orange, these are the wild type BRAF and PTPN11. The blue are the ones that have the mutations, and the pink are the ones that we do not know. So you can see here, we were capturing some of the patients that live long in spite of not having the mutation. So we're suddenly identifying the patients that actually will do well, even though they don't have these mutations. So with regards to whether we can make this same analysis be reproducible in a separate cohort, I reached out to my colleagues at UCLA, and Robert Prince was really instrumental in these. They had recently published a paper along with us in Nature Medicine, where they showed that their PD-1 blockade would exhibit better survival when given in the neoadjuvant setting. And in this case, I asked them whether I could get access to the samples of patients that were treated in the adjuvant setting. And so what was really interesting about this is that they gave me 2 samples per patient. One sample from when the patient was first diagnosed, and another sample for when the patient was started on the clinical trial. And the first thing we wanted to know is what happens over time to phosphorylated ERK. And the answer is actually really interesting and chaotic. It's a mess. Basically, most patients that had elevated PERK at diagnosis became low PERK at recurrence when they started immunotherapy. Most patients that were low became high. So it was completely erratic. And what's interesting is if you take the at diagnosis PERK levels, they wouldn't really predict survival of these patients when the tumor recurred and you gave them PERK perhaps a year or two, you give immunotherapy perhaps a year or 2 after. This was not really going to work if you use an obsolete specimen. Yet, if you take the samples collected on study when the patient got surgery during the clinical trial and they were started immunotherapy within a few weeks, actually there was a very nice reproducibility of our previous finding, and you can see the patient that had high PERK had longer overall survival than the patient that had low PERK. This was true in the univariate as well as the multivariate analysis, and the area under the curve in this case on this raw curve look even better than on our discovery cohort. And so we now have established this correlation between PERK, but it wasn't really clear. First of all, who is expressing PERK? When you do immunohistochemistry, you can't really tell necessarily that these are the tumor cells, but also what's different about these tumors? Why is PERK associated with this outcome? And so the first thing we did is a multiplex immunofluorescence analysis where we started looking at which cells had higher levels of phosphorylated ERK. And the SOX2 is a marker, established marker for gliomas, for glioma cells. TMM119 is for microglia, and CD163 is for myeloid cells. And what you can see here is most of the expression was by tumor cells. Other cells contributed as well, but really most of the PERK was coming from the tumor cells. The other interesting thing, as we are expecting, is the patients that had high PERK, defined by the median, by immunohistochemistry, which is the biomarker that we use for predicting response and survival. Their SOX2 positive cells were the ones that were expressing more PERK. What's really interesting also is that these patients also just had much more microglia in their tumors, as you can see right here. Interestingly, the myeloid cells, which tend to infiltrate the tumors, had really not much difference between high and low PRK patients. It was really the microglia that was much more abundant in these patients. And when you look at this marker, IBA1, correlated really nice with phosphorylated ERK by immunohistochemistry. So here you can see some representative multiplex images where SOX2 are the blue cells and the green cells are phosphorylated ERK cells. And you can see how this patient that had a lot of PRK had a lot of TMEM119. You can see there's a lot of purple, and also that the PRK is expressed by the SOX2 positive cells. This other patient that also had elevated PRK but did not have the BRAF mutation had a similar findings with a lot of microglia and the PRK expressed by tumor cells. And this patient had very little expression of phosphorylated ERK, as you can see here, also had minimal microglia in there. So there's something special about microglia, we thought, and we wanted to investigate that further. So the first thing we said, well, if there's more microglia, perhaps microglia are closer to PRK positive cells. And you might think of this as an obvious conclusion. And we proved that. And I think it is obvious, but might actually have some mechanistic meaning, because if the tumor cells have this signaling cascade activated, and that is leading to an enhanced immune response, and there's more microglia, I guess if they're closer, there might be an opportunity for this to have some paracrine interactions or signaling or communicate by some means. And so we did this analysis where we were measuring the distances, and what you can see right here is that the distance of SOX2 positive, PRK positive cells to microglia was shorter when the PRK patients were high compared to when they were low. But for the PRK negative tumor cells, there was no difference. And we found a similar trend for myeloid cells, but not when the PRK was negative, for PRK negative tumor cells. We did the same analysis using GFAP as a separate marker for tumor cells. No marker is perfect. SOX2 is maybe more specific, but might not capture all the cells. GFAP might be more widely distributed, but might also be labeling some astroglial cells that are not necessarily tumor, but actually showed a very similar result. So clearly tumor cells that have elevated PRK were somehow closer to microglia than the negative. And so we wanted to really understand whether there was anything different to these microglia cells. And we wanted to do this in a way that was unbiased. And so in order to do that, we did a paired analysis. We took 10 patients for which we could stain for PRK. So we would know the phosphoproteomics aspect of MAP kinase signaling. It's the best way to determine whether this pathway is activated. But the same 10 patients were also analyzed by single-cell RNA sequencing. And so we split these 10 patients into patients with high PRK and low PRK using the same definition as we used before, which is the median. And we looked at the different cellular components by single-cell RNA-seq. You can see different things segregate very nicely. You can see here the high PRK tumors are separate from the low PRK tumors, as you can see here. But this cloud right here represents the cluster of cells that are myeloid cells. And what you can see right here is that high PRK, myeloid cells from patients with high PRK tumors tend to localize at this lower area of the cloud. And that's the area of the cloud that had also enrichment for several gene sets, but most importantly, MHC class II expressing protein complex. And so here's a gene ontology analysis of the genes that were differentially expressed in the myeloid cells of the tumors that from high PRK versus low PRK. And you can see MHC class II protein complex is the top theme, but there are other interesting phenotypic differences related to T cell activation and several other immune-related responses. We focus on the MHC class II because it was the most robust finding. And of course, RNA should in principle always be validated. So we went back to these tumors and perform an analysis of multiplexing like we did before, but now to ask the question of whether MHC class II was more expressed in the microglia cells or in the myeloid cells from patients that had elevated PEERK. And what was really interesting is, you can see right here, microglia, which is labeled by TMN119, had significantly more MHC class II expression on the patients that had high PEERK versus patients that had low PEERK. Whereas myeloid cells showed a similar trend, but was not maybe as strong. So we really think most of the action, at least phenotypically speaking, in the microenvironment is different in the microglial cells, as opposed to the myeloid-derived suppressor cells. So I'll try to keep it short. I'm going to just conclude a few things here. But immunohistochemistry for ERK1/2 phosphorylation, otherwise colloquially known as PEERK, showed that a PEERK was predictive of response and overall survival following adjuvant PD-1 blockade in a discovery and an independent validation cohort. Whereas not all tumors with elevated PEERK were responders, all responders had PEERK elevation. So the question here in my mind is PEERK MAP kinase maybe necessary but not sufficient for response? I'm sure there's more to response than just this aspect. Timing of biopsy really influenced prediction. I really think this is important. We often do surgery and recurrent glioblastoma for symptomatic relief. If this biomarker were to be validated prospectively and this were to take off, I think there would be an indication to perform surgery to actually get fresh tumor to run this kind of biomarker. PEERK was mainly localized to tumor cells. Elevated PEERK in glioblastoma contained tumor-infiltrated myeloid cells and microglia with elevated expression of MHC class II genes. And most importantly, as excited as I might be about this work, I'm not sure this is ready for prime time. It is interesting. I consider this to be hypothesis generating. But in order for this to make it mainstream, I think prospective validation and proper clinical trial needs to be done. This is probably the most important slide. I have really, I'm just representing here the work of many people in my lab. We are a growing group. I have several very important collaborators. I mentioned some of them today, including Fabio and Raul, but I have also very generous support from NCI, NINDS, and the Office of the NIH Director, as well as philanthropic support here. So I will finish right there, and I'm happy to engage in the discussion. Look forward to it.
Great talk, Adam. That was really some phenomenal work, and it's really helping us understand how to unlock immunotherapy, which has been a mystery to, we've all been so hopeful for it for such a long time. We've seen the vaccines come through, we've seen immunotherapy come through, and it's been so depressing to the clinical and research society just to not see that, even though we all feel like there's still something there. So this is a great step forward in trying to unlock that to see how we could use it. I had a couple questions. One was, you showed that great correlation of the microglia at the end to the high PEERK concentrations. And so how do you know that it's just not tumor cells that have a more robust microenvironment, or tumors that have more microglia and that's the main cause of them responding more than just the PEERK?
I think this is a great question, and I think it speaks to the limitation of the study that I did. Everything I'm showing you done in humans so far is correlations. There's no causality in any of the slides on this talk. In order to look at causality, you need to mess up with PEERK in the tumor cells and see what happens to the environment. And I do have some work related to that I'm not presenting today for sake of brevity, but it's a great point. I think what's clear to me is that elevated PEERK in the tumors comes with more microglia that are different. I can't really claim that it is because the elevated PEERK that this microglia is different. Totally agree with you.
Yeah. So that's kind of a setup to the second question, which is a little bit more general, which is, it's so great to see somebody who's a surgeon really taking the samples from patients and working the problem backwards, versus a lot of us are, trying to work in the lab and use cell lines and mouse and whatnot, and then try to then take that into humans. And I think more of what you're doing is needed. But it brings up the question of, how do you now reverse engineer this? How do you take this back to the lab and set up a model where you could do exactly what you just said, is to up-regulate, down-regulate find the pathways and interrogate that? What is your solution to the models for immunotherapy?
Yeah, no, I appreciate this. It's a great question. You know, there's this saying out there, all models are wrong, but some are useful. A great statistician said that at some point. So I think, and I'm very humbled by all of these, I think it's very hard to start a project in vitro and then get a mouse experiment that shows what you expect, and then suddenly expect that to make a survival difference in a clinical trial. I think a lot of very, very transformative research started with a clinical observation. And so I think it's less risky, even though it might seem more convoluted, to start with a clinical analysis. What I like about the work we've done, and I think was somehow kept us in check, is that we started super unbiased. And so the hypothesis is, if there is a gene that will make a difference, we're going to find it because we're looking at all the genes. And so if you have something to start that is super unbiased, then working your way into more hypothesis-driven research, like, okay, we found MAP kinase after looking at all genes. Well, can we now focus on MAP kinase? That's what we did on the second paper. And then from there, going from correlation to causality, well, can now we mess with MAP kinase and see whether we can change that? And that's now a reasonable thing to do in mice. But that's been my approach, or at least what I thought was helpful in this story, is to start unbiased human observation, maybe start with a strong correlation and then lead to causality. In a short answer to the other question you mentioned, we've done some provocative experiments where we basically using CRISPR to knock out all the kinases in the genome in tumor cells, and then we inject them into mice. And intracranially, and then you can see the contribution of every one of the kinases, including MAP kinase or not, to see whether they really contribute to response to immunotherapy or not. So this is some of the work that we haven't published that we're wrapping up right now to send out there. But there's very nice things you could do if you start with a hypothesis, right? You could do this for kinases, or you could have done it for epigenetic modulators. Well, we chose kinases because we already have all these human observations there. So I don't know, in a short answer to that, but I agree with you.
Great. Yeah, let me open it up to the rest of the panelists here, see if they can answer questions.
Hey, Adam, great talk. I definitely remember that patient that you're referring to in a lot of days on rounds and a lot of sessions trying to manage a difficult post-op period. But great talk, great body of research and inspiration to all of us surgeon scientists. I guess to piggyback off, Dr. Ivan's question, do you see, I guess if you were to overexpress or overactivate the MAP kinase or ERK, do you think that would convert a non-responder into a responder?
Yeah, I think it's a great question. I really believe that MAP kinase is necessary, but not sufficient.
Okay.
And so I think it might work in some occasions, but not in all, as we see on the data. I don't know that it could happen without it, but I think if everything else was inconvenient, maybe tumor is not antigenic or whatever reason, I don't think it would work. So I don't think it's a holy grail.
Okay. And do you think, I guess to follow up on that, ERK is more of like a readout for response in the pathway, or do you think it's actually playing a pivotal role in terms of generating the response to treatment?
Yeah, it's a great question. So we have actually knocked out and overexpressed phosphorylated ERK, and we do think ERK itself contributes based on mouse experiments that I did not present here today.
Okay. And I guess one last one while I have you. And there's a pretty strong link between ERK and integrin activation. Do you see any changes in tumor invasiveness between the patients in your responders and non-responders, given that ERK may provide a higher integrin activation and have more invasive tumors?
Yeah, that's a great question. I have not explored that at all.
Okay.
So that is interesting. This is why at some point, paper takes the life of its own, and we deposit the data, and smart people like you can do analysis beyond what we originally thought of. But no, it's a great question.
Cool. All right. Thanks, man.
Thank you.
That was awesome. That was a great talk. Just a quick question. I think Dom and Dr. Bryan both sort of asked a question. They just cut off there. Sorry, asked a question that I was thinking as well. But you mentioned in the last slide, sort of necessary but not sufficient. Any leads on anything else that you could be thinking of that could play a role in what you guys have done so far? Or I guess I'm kind of asking you to tell me what else you guys are working on, sort of. But anything you can share with us?
Yeah, I mean, I would say this in a humble way. I don't know that what I mean by necessary but not sufficient is we clearly saw patients who had high PERC that didn't live long. But we never saw patients that had low PERC that live long. And so I think there's a T cell component to this. We clearly see T cells. I think you need antigens, right? So I don't know that PERC solves the equation if the tumor is not antigenic. But I also don't think a tumor that is antigenic when there's no good microenvironment, if you will, would help. But I don't know the answer to your question. I'm still perplexed and trying to think about it. Want to be open-minded. There's so many smart people working in immunotherapy. But I do think that the intrinsic tumor signaling and MAP kinase plays a role.
Oh, thank you.
Thank you, Dr. Solomon. Really exciting findings. Congratulations. I have two questions for you. The first one is if you think that the location of the biopsy can affect or bias the results when assessing PERC expression.
Yes, sure. So I definitely think there's I would say, intratumoral heterogeneity in MAP kinase signaling and PERC. And one of the things I'll tell you, the quality of the biopsy is super important. What we did really to level the plane there is we had our neuropathologists look at all these samples, and they would just tell us and delineate the area that has tumor, and occasionally they would just tell us this sample is garbage. Like you can't really be looking at tumor in this one. And we did this with the H&E. So yes, good biopsy is important. A larger biopsy gives you a more representative sample to look at. What Victor did is he sampled as much as he could. And, in spite of the intratumoral heterogeneity, I think the differences across patients were robust enough that we could see who would live longer or not.
Thank you. And for the second one, in your experience working with sonication, do you think that it can be useful in the context of checkpoint inhibitors?
Yeah, it's a great question as well. Very, very nice. It's a topic for another Miami Symposium talk.
The next one.
We do think we can, and there's some evidence from several groups that actually immunotherapy can enhance its penetration across the blood-brain barrier with this ultrasound technology. And we have a clinical trial program looking at this. Yes, my results are not as mature as I wish right now, so we might need to wait a little bit before we schedule that one. But it's definitely playing a role.
Thank you.
And then we have a couple of questions here in the last minutes from the audience. One wanted to know what your correlation between PERC was and IDH1 status, which I think you showed, but I'll just add to that. Do you feel like you had enough of the IDH1 mutant to kind of really fulfill that answer, I guess?
Yeah, it's a great question. The answer is worse than the question. I wanted to do the analysis with as many patients as I could, so I did not exclude the IDH1 patients. As expected, demographically, they represented about 10% of our samples. And so with very little samples, I have a very hard time making any claims. I don't think I'm powered to look at whether PERC is different for those patients. It's another good question that could be looked at by other cohorts and groups, but I don't think we have enough patients to answer that.
Are you gonna redo all those papers with CTL4?
Well, a great question. I think the main point here is, I was very disappointed. There's this moment at SNO once a year, right? Where you sit on this very large auditorium and you listen to the latest 700 patient phase 3 trial that is completely negative. and you walk out of that room, and this happened again this year with another checkpoint blockade study, and you really ask yourself, okay, it's negative, but what did they learn?
Yeah.
And I tell you anecdotally, I reach out to BMS to get the samples from these trials to do the same analysis, and they don't have it. And so what I think it's unfortunately sad is you could do
Which is ironic because they ask for like 10 vials of tissue when they do the trial, right?
So it's not there. Or, you know, the point is negative trials are sad, but trials that you don't learn anything from are even sadder. And so I think the opportunity to do really cool research as clinicians, it's really basically based on the ability to get samples that are linked to clinical outcomes. And so if I had those samples in my hands, I would absolutely run with it. But that's the way of, you know, any of us doing good research. We would need to just be organized and figure out how patients are being treated and which samples correspond to what patients. And then you could do all these interesting clinical observations.
And then, you know, I know we have a lot of younger people on the talk from around the country. And so I wanted to also touch base on your success with all of these papers that you've been getting into these amazing journals. What advice do you have for preparing, you know, good experiments, and also knowing how much to put into a paper to dice it up appropriately for a top journal submission like you've done it so many times now?
Yeah, I think it's a good question. So I will tell you a few things. First of all, good journals are not good for your career. It's really interesting, but there's really good journals that are not these journals, and they're very reasonable. These journals are really picky and they're very difficult. And honestly, some of my mentors really advised against these. So I would really not focus on the journal, but if you wanted to try some of these, which do it at your own risk, it's good to have simultaneous productivity in journals that are not as picky, so that you don't bet all your career on that one paper. But if you're going to try these, I think a few things are important. First of all, human data does well on big journals. Again, you know, if I was doing a story with mice, the bar would be much higher. But if you're doing an original observation linked to patients living longer or shorter, that's already going to be taken way more seriously. So from the get-go, if you want to publish a paper like this, I think it's really good to just work with human specimens and link to data. I think that's the first thing I would say. Second, I think it's very important with these journals to have one or two claims and to write it in a way that you are very, very neutral about the results, and you're not selling a used car. You're just basically showing what you found. And the more independent ways you can show the same thing is better than having too many claims. So the main reason why these papers are not reviewed is because the claim is not big enough. But you don't, if you send a paper to a journal and it doesn't get reviewed, you know, nobody lost anything. You lost a week. But if a paper goes to one of these journals and gets reviewed and a year later it's rejected, it's not because the claims were not big, it's because you couldn't rigorously prove that claim over and over. And so going back to this story, I'll tell you, this second paper that we published in Nature Cancer was under review for a very long time, and everybody agreed that it was very important work, but nobody was convinced that we had, you know, correctly addressed rigorously whether the samples were of high quality and whether the staining was specific. And so finding 1,000 ways to prove the same in a rigorous way with an open mind that you might actually not prove it, and then the reviewer might be right and you might just learn that you were after an artifact, I think it's a good strategy. But it's a risky strategy. I think I try to do a lot of papers that are not going to journals like this.
That's great advice. That's great advice. Okay, anything else? All right, well, thank you so much again, and congratulations. You guys are building a powerhouse there at Northwestern, and so keep up the great work and stay safe.
Thank you, and thanks, Ivan, Mike, for all this amazing symposium. I always enjoy it.